Hi, everybody. So, Helen, if we can go to the next slide, please. So, what we know is that this group care model is really aligned with person-centered care. And the important thing about person-centered care is that it has two elements to it. It's about the people and the carers who we're supporting, and it's about the caregivers. So, we want to create a caring experience where both the caregivers feel in control and are able to be part of a session that deals with what matters to them. So you have within your practice of health and wellbeing coaching or social prescribing possibly certain templates that you have to complete. So the group care process has to be aligned with that, and you do that through the results and topic boards. But we also know that group care, as opposed to one-to-one appointments, have really positive impacts on outcomes. So randomized controlled studies have shown that when they are seen in a group clinic, patients trust their practitioner more, report higher satisfaction levels, report a more personalized experience of care, and that the group care model improves the communication between carers and patients after the session. So these are really powerful benefits that are going to be realized when you deliver your personalized care in a group setting compared to a one-to-one appointment. Studies also show that practitioners report that group clinics are energizing, support a really much deeper understanding and relationship with patients, avoid repetition, and restore a sense of autonomy when sometimes some assessments can feel a little bit kind of protocol driven or tick boxy, to use a technical term. They also have been shown to increase job satisfaction. So if you can relate to that as a personalised care practitioner, some of that sense of repetition, some of that sense of, oh, I feel like I'm following a template sometimes, that and sometimes that one-to-ones can also be quite difficult because you're taking on a huge amount. When you're in a group environment, you're able to, by sharing their experiences, people get energized. It's not just all about you being there for supporting the person, the group supports them too. So, um, so that's the first thing to note. The second, so let's move on. The other thing about group care is that we know that it improves outcomes. When we've been working with health and wellbeing coaches and social prescribers, we've found that a lot of the time, some of your work is about providing an adjunct to clinical care. So working with people with pre-diabetes, with hypertension, with diabetes, asthma, COPD, to help them to actually manage their condition. So studies, again, have compared one-to-one appointments with group clinics, and there are measured improvements in quality of life, understanding and knowledge of their condition, patients feeling more able to self-manage their condition, feeling less isolated and alone, and feeling more validated and understood by their peers and by the practitioner. Really, really important in relation to health coaching in particular, but also social prescribing, is that compared to one-on-one appointments, patients make and sustain more health-related behaviour changes after attending a group session. So that is really key. A lot of you are asking about references and slides and stuff. We don't share the slides. We will send you out a document which has the references in. So there you go. Really, really powerful stuff based on the evidence. Third slide, please. So have we got the third slide? Thank you.
Yes, it's on screen.
No problem. So the other thing to think about in relation to the challenges that we face around delivery within healthcare at the moment, and particularly in relation to personalisation, is that personalisation has four different elements to it, and the group model supports all of these. So you've heard from Helen how the group clinic model results in people getting some information before they're joined by their personalised care practitioner, that they then have a clinical session where they a session with them where they've already had a chance to think about their questions, and that the session ends by putting together some personal actions and setting goals. That mirrors the care and support planning approach, which is fundamental to chronic disease management. And so that is very much aligned with the universal personalisation approach. Shared decision making happens naturally in a group clinic because people have discussions about what's working for them and what they can do to improve their situation. And that supports the shared decision making because people do not only get ideas from their personalised care practitioner, they also get ideas from their peers. Social prescribing and health and wellbeing coaching are key to the personalization agenda, and this happens again very well in a group setting. And supporting self-management is also key to personalization, and as I've already alluded to, the evidence suggests that a group care model is even better than one-to-one care at supporting self-management. So you are delivering personalisation through the group clinic model. Helen, next slide, please. And I think we're over to Alicia. Alicia, handing over to you now.
Hi, Georgina. Thank you. So as I was introduced, my name is Alicia Jenkins. I'm a programme manager for Personalised Care in Herefordshire, and I'm on secondment for a year from my substantive role as a health and wellbeing coach in one of the PCNs. So if we can go on to the next slide, I will share my experiences in group clinics in practice. So as I said, I am from Herefordshire, and that is a place that runs on the border of the middle of Wales, and it is truly stunning, but it is one of the smallest and most rural counties in the UK, with a disproportionate elderly population. So just to set the scene, the opportunity to receive training in group clinics sort of arose in autumn of 2021. And that was sort of in the wake of the COVID pandemic. So, everyone was still terrified of going to Asda. We were in that awful tier system. Nobody wanted to leave their homes, which was quite reasonable. So we had quite a challenge of reaching those people that were geographically dispersed, not meeting face to face, relatively elderly. And to add to those issues, we had some quite long waiting lists for our health coaching service as well. So as I said, I was working as a health and wellbeing coach, and I will go back to that role when I complete my secondment in March. And essentially, the service had started in the August, and within a month or 2 months, referrals were coming in exponentially. So word of mouth among the clinicians and among the healthcare professionals in the PCN was really helping to build our waiting list. People were hearing about the improvements from health coaching around the clinical markers for people with pre-diabetes and their CVD risk scores. So we were quite popular, which made our waiting lists quite long. So the opportunity to utilise online group clinics sounded like a very good idea to help to support some of these issues that we are facing. And I have to admit, I was a bit speculative on that first call with Georgina, just because of the digital problems that might be associated with an ageing population and the rurally dispersed population with the Wi-Fi issues. But some of those judgments or pre-misconceptions have truly been eradicated after being involved in group clinics for a while now. So definitely my one piece of advice is don't go into it with any sort of prejudgments about what people can and can't do, because you'd be surprised at the abilities of people in terms of their digital access and their digital abilities. So that was enlightening for me. So and just to sort of set the scene a bit more, the people on the waiting list for their health and wellbeing coaches are people with pre-diabetes, and they're living with obesity as well. So we asked that people that have sort of already been seen by the health coaches and are already on their active caseload, we asked that they'd have at least 4 to 6 of their health coaching sessions as a group clinic rather than just a one-to-one. So it was quite a good model. It was quite successful, and we utilised our outcome measure, the WHO5 Wellbeing Index, to form part of the results board, which you saw a few slides back. So the health coach was the personalised care practitioner, if you like, and the care coordinator acted as the facilitator stroke clinic coordinator. So moving on to the benefits and the impacts that we had a comfortable reduction in our waiting list. You know, we had about 10 people on the group clinics. So as you can imagine, seeing that many people all at once saved a huge amount of my time in the one-to-ones instead of having the group clinic instead of those one-to-ones. And it released my capacity to see the people that were on the waiting list and get them onto the group clinics as well. So it was really valuable in helping us manage that waiting list. And particularly with people that are trying to manage pre-diabetes, the sooner you can see them and the sooner they can act on their health, the better their outcomes might be. So we recorded people that had lost the weight that they wanted to lose. We had other outcome measures from our wellbeing index as well. So it was health and wellbeing that was improving, which was really, really excellent. So it's really important to understand the value of the group as well. So quite often I'd find that a person would take the advice from the group and take it in their stride and act on it more often than they might in a one-to-one. And I think just sometimes hearing it from somebody else that may have already gone through a similar experience, or they're in a similar boat, that power of the group and the group's wisdom really comes through to help people, to give them the push that they need to make some of those lifestyle changes. So that was really, really invaluable to some of the people that I've worked with. And we did notice when we recorded the outcome measures at the end that there was a wellbeing index improvement by at least 10 points, I think was on average. So I think that's a cause for celebration. And I think really importantly as well, we noticed some of the peer connections that were being built. So following doing sort of the health coaching group clinics, we also did a series of group clinics for people living with fibromyalgia. And I think it was the middle clinic that we did, because we ran a series of 6. It was in the middle clinic that I noticed that people were exchanging their contact information, and they were actually looking to build a bit of a craft group together. And I think that is just invaluable, watching those connections, and they are so key for people in prevention and continuing to stay well. And you know, you can't put a value on that really. So I think that's a huge benefit of group clinics. And then just from a sort of slightly different angle, it's a really exciting way to work. It's something different. It's something innovative. It sort of demonstrates that you and the organisation that you work for are working in a new way, and you're striving for digital improvements if it's online. But it's just also a great demonstration that you as an organisation are investing in improvement projects for the benefit of your local population, and the benefit of the organisation as well. So in terms of next steps, as I said, we've sort of run the fibromyalgia clinics as well. And we actually got a variety of health professionals involved in that one. So in the North and West PCN, we are quite lucky in that we have got a big wellbeing team. So there's 2 health coaches, there's 3 social prescribers, there's a dietitian, there's an occupational therapist, there's a mental health practitioner. So utilising all of those skills from those personalised care roles, we were able to offer a variety of themes and topics for people to come and talk about. And we did a cohort online and we did a cohort face to face. And so that was a brilliant use of sort of targeting a particular group of people that might have been part of a bit of a health inequality in Herefordshire. And since I've gone on my secondment, I'm really pleased to say that the health coaches that are in their roles in that PCN have continued the work on group clinics, and they've recently just published some information about one that they've done on hypertension, and they've actually recorded their outcomes in a much better way than I did when I was doing my group clinics. And they've recorded the improvements to knowledge, skills, and confidence in the variety of areas and the themes that they've talked about. So they've also measured the patient activation improvements as well. So they recorded an improvement of at least 1 point up the scale of patient activation. And we know there's quite a lot of hard evidence behind patient activation. We know that there is, I think it's a 1 point increase on the scale is equivalent to a reduction in about 5 GP contacts per patient per year. And there is a monetary value attached to that as well. So research has shown that a 1 point increase in patient activation is equivalent to I think it's 320 something pounds per patient per year. So the fact that they've been able to attach that monetary value is important for the stakeholders and the commissioning of the services to enable those services to continue and exist to help the populations in Herefordshire. So that's really beneficial, and I'm really pleased that I've seen that carry on whilst I've moved away from that role for a year. But I'm so excited to get back and continue with the group clinic agenda when I start again in March of next year. So there are a few more things that we're looking to do. So we're actually in conversations with experience-led care at the moment about utilising our clinical services at the GP Federation in Herefordshire to look at doing some group clinics on things like menopause, which we've heard have worked well in other areas. So there's definitely space to continue this and definitely space to improve even further. So thank you very much.
That's fantastic. So we've got one question, and I'm going to take it at the end after Gosh's presentation, if that's okay. Guys, do keep posting questions into the chat because we will have time for a Q&A.
Oops. Okay, we've lost Georgina a little bit. So Gosha, I'm going to ask you if you would like to share your story with us, please.
Sure. So thank you for joining me, everyone. So my name is Gosia Chmielewska. I'm a social prescriber link worker at the Great West Road Primary Care Network in Hounslow in London, and also community environmental charity Groundwork London. And I'm also ambassador of the Personalised Care Institute. And yes, I agree with everything which Alicia said. And I will hopefully add a few more things maybe to it. So today I would like to share light on how group care models can amplify the effectiveness of personalized care. Let's begin by understanding the fundamental value they bring. So firstly, group care models offer a space where diverse perspective and mutual support flourish. Imagine being a part of a group of individuals who share similar health challenges or goals. So take a moment and pick something personal to you. For example, I don't know, maybe suffering directly from asthma attacks or migraines or low energy, anxiety, or anything, just as long as it's something personal to you or to your loved ones. Okay, hope you got it. And then imagine that all of us are in this group suffer from it too. So in this setting, you have the opportunity to share your experiences, express and also receive empathy, and provide support, and again, also benefit from peer support. I think this is very, very important. Because it's like having a ready-made community of people, like your tribe of people who understands what you're going through. And I'm sure especially those ones of you who maybe were unwell in the past, they know how valuable, how important this really is, and how often our patients just say they feel no one gets them. So having that community, it's very, very important. But group care models aren't just about emotional support. They also offer a cost-effective approach to healthcare. By leveraging the power of groups, we can stretch our resources further, making quality healthcare accessible for larger population. And this is crucial in a world where healthcare resources can be scarce, costly, and time is precious. I'm sure most of you working for the NHS can understand that. So imagine for a moment a scenario where group diabetes management classes are held. And here patients learn about dietary management and self-care techniques. Now, the cost of such a class per participant is significantly lower than one-on-one consultations. And this enables more individuals to access essential education and support, and ultimately leading to better health outcomes. Moving on, the benefits of group care models extend far beyond cost saving, although cost savings obviously are important. They provide platform for education and skill building. So think of a group sessions where healthcare professionals impart knowledge, tools, and strategies. And these sessions empower patients with the information and skill they need to take control of their health effectively. Moreover, a group of models foster a sense of community. They reduce feeling of isolation and loneliness by creating space where individuals facing similar challenges can connect. And this sense of belonging can significantly impact mental and emotional well-being. And there's so much studies being done on how lonely people actually can feel, especially again when they suffer, when they are unwell. And group settings also encourage behavior change and accountability. Knowing that you are part of a group can boost your motivation to make positive lifestyle changes. Peer encouragement and shared sense of responsibility can be powerful drivers of behavior change. When people know that they are part of a group, they're more inclined to make positive lifestyle changes and adhere to treatment plans and achieve their goals. It's a form of built-in accountability. And this is where the magic of peer encouragement and shared responsibility comes into play. I mean, this is such an important point, because it's not only about getting the knowledge, but also to see behavior change. So for instance, think about a group weight loss program. In this environment, participants motivate each other. They hold each other accountable and celebrate the victories together as well. The shared goals and aspiration create a sense of responsibility that can be a powerful driver for behavior change. Well, I experienced myself many times. It's much more easier to be part of a group. I mean, recently start running again, and yes, it's so much easier to do park run with others on Saturday than do it, for example, on my own. Now, let's see how group care models works in practice. Well, they embrace a holistic approach, recognizing that health is not just about the absence of disease, but about complete well-being. So again, we're talking about that holistic, personalized way of looking at things. These models address not only physical health, but also emotional, mental, social aspect, resulting in more comprehensive approach to healthcare. Furthermore, group care models can serve a valuable source of data collection and research, which has already been mentioned. An insight from group interaction can inform healthcare providers and researchers about effectiveness of specific interventions, allowing for continuous improvement of our existing care models. Resource pooling is another advantage. By consolidating resources like, for example, equipment, facilities, or healthcare professionals, we can minimize waste and make more efficient use of limited resources. Well, in conclusion, I believe that group care models are game changer in the world of personalized healthcare. They offer diverse perspectives, support, cost efficiency, education, community, behavioral change, shared decision-making, and holistic approach to well-being. And they also provide opportunity for data collection and research and optimizing resource utilization. But as with any innovation, there are challenges to overcome, including potential hurdles in group care settings. However, the advantages are profound and the benefits far outweigh the challenges. And Alicia already covered some of the challenges and how they were overcome. And I would like to stop at this point. And if there are any questions, Alicia and I are happy to answer them. Thank you.
That's fantastic. Thank you both. Really, really useful presentations, and looking at it from slightly different perspectives and really complementary. And I know, Gosha, that you've also run quite a lot of group sessions yourself, haven't you? So
yes.
When it comes to some of the practical questions that are coming up, I think you can probably both contribute for that. So I'm going to just feed the questions to you so that you can, and thank you for everybody for posting. So there's a really practical one, which I know for you, Alicia, because you have mainly done video group clinics, maybe isn't so relevant because the question is from Ruby, and it's how to overcome some of the access challenges. And what Ruby talks about is transport and a space for the face-to-face clinics. Do you want to say something about how video group clinics overcome those issues for you in Herefordshire, where you're obviously very rural, but also tell us a little bit about that digital interface and whether or not that did actually end up proving a barrier, because I know we were all worried in the start, weren't we, as you have an older population. So say something about how this has helped, what people tell you about how this helps them with transport and stuff.
Yeah, well, like I said, we had those issues around rurality, and the transport links are absolutely dire over here. So having that group clinic online was an opportunity to sort of mitigate some of that. And like I said, I was worried about the people not having the digital skills to do it. And yes, there were some people that said absolutely no, I'm not going to do that, but it was much less than I thought it would be. And actually some of the people that did have digital problems were a lot younger than I thought they would be. So some of those misconceptions that you have aren't necessarily what's the reality. But as time went on and things became more opened up following the pandemic, we did offer face-to-face groups as well. And you've asked about struggling to find the space to do them, and within general practice that can be a big challenge. We have worked quite closely with the community hospitals that have offered us big spaces, particularly because it's a rural county. The sort of community hospital that's in that area, the large rooms aren't really utilised very much, so there was a lot of space to use there. But we also have a brilliant council-run leisure centre, which has sort of partnered with the NHS really well, and they've offered us use of the fitness spaces. So when I did the fibromyalgia group clinic, we did the face-to-face one there in the fitness space, and that kind of set the scene really as well, because one of the sessions, one of the themes was around like staying well and being fit and active. So bringing them into the leisure centre helped to stimulate some of those thoughts as well. So that's how we did it anyway in our PCN.
Absolutely. So space can be an issue, can't it? But community spaces can be really helpful. Gosia, have you got anything to add to that?
I absolutely agree, Alicia. I've done loads of kind of digital consultation, and actually in my previous role, not as a social prescriber, but as a group facilitator, I done a digital project for elderly and in a care homes, and some of them were 90, first time, never had even mobile phone. And Yes, like with everything, you can actually, if you want, you can learn. Yes, there will be some difficulties at first, but it's just joy to watch, to overcome those problems. And it's error and try, and I'll just say go for it. And also it's
Brilliant.
opportunity for those kind of people who are not good with digital skills to improve their skills as well.
Absolutely. And that nowadays, that's a real source of inequality, isn't it? When people can't, interact digitally. DNAs was mentioned as well. And I think the key thing with DNAs is you will always get them over invite, to compensate from DNAs. And remember that having DNAs, the benefit with a group clinic is it might be a little bit shorter. You're not actually going to be wasting time between appointments waiting for people who DNA. So yes, DNAs, we have to recognise it, but it's a very surmountable problem. I'm going through all the barriers now quickly from the chat. So another one that people have mentioned is people with anxiety and depression who don't feel confident about attending a group clinic. I've seen this myself working with people doing long COVID group clinics, and fatigue is often an issue for those people as well. And it's often an issue for people living with chronic pain, fibromyalgia, things like that. Any tips around how to get people with a bit of social anxiety and depression to participate? I'll start with you, Gosha, and then come to Alicia on that one.
Okay, so I remember some patients exactly feeling a bit anxious, and I think it's also about the preparation and setting the scenes, and just to be aware of that patient can be like that. So for example, there were some patients which they decided not to have a camera on, and that was absolutely fine because we understood there might be other reasons behind it. Some people, they were anxious, for example, how did they look, how they come across. And again, it was beautifully to watch how the space changed as well, that people were not wanted to be to have a camera on, and then they had cameras on or not participating. So it's about not putting pressure, but it's always about holding the space in a nice and kind of kind way, and just to be very, very mindful that there might be some problems which the patient might need a little bit of a hand holding.
Absolutely. So in some ways, the group clinic provides that space for them to just listen and participate in their own way, doesn't it? As opposed to a one-to-one. Alicia, does that fit with your experience as well?
Yeah, definitely. I definitely agree with what Gosha said. And in the area that I work in, one of the things that we did with people that were feeling particularly anxious about joining the group clinic, because of the model that we used and the way we did, we had the one-to-one health coaching sessions supplemented by the group clinics. So we could spend some time in a one-to-one at the GP surgery in our normal consultation, talking about and building up to joining a group clinic. So it almost acted like one of their goals that they'd reach. And it's the way you approach it and the way you sort of almost sell it to people. And it was I'd say you don't have to have your camera on, you don't have to say anything, just join for the first one. You don't have to participate if you don't want to, just come and try it out. But there's no pressure. So like Gosha said, you can see people evolve and you see people gain more confidence, and often there is more than one person within the group clinic that is full of anxiety, doesn't want to say anything, but as soon as people start talking, you can see that sort of domino effect of the confidence building within the group. And because of the model that we use, like I said, we had the one-to-ones as well. When I've spoken to those people that did have quite a lot of anxiety afterwards in our one-to-one, they've said, yeah, it was completely fine, and it's one of those things that they're glad that they did, because it's helped on their journey to improve their anxiety. So it is a barrier for some, but it's definitely a stepping stone to health and wellbeing improvements for lots of people.
Yeah, one of our participants has been asking about case studies for people living with pain using group clinics. And just out of interest, I had one physiotherapy team I work with in Wales who were doing a group clinic for people with MSK pain, and many of those patients also suffered from anxiety, and many of them were sort of, you know, housebound because of the level of their anxiety. And one of their outcomes was that at the end of the program, one patient in particular who had very big anxiety issues turned their camera on, and that was like the celebration at the end of the program for them. So I think it is definitely something that can support people with anxiety. And Susie, you've also asked about reducing prescribing of painkillers and opioids. There's actually quite a lot of published evidence around that, studies that have been done. I think talking to people who have approached this kind of model as a group clinic, I think you need to think really carefully about it and make the deprescribing something that is a secondary outcome, and make managing chronic pain the primary outcome, you know, living with your pain the primary outcome, and then people will naturally start to feel less dependent on their opioids. So there's a lot about how we frame that, but if you'd like to pick that up, I can share some of that evidence with you afterwards. So okay, I've also got a question specifically for Alicia, which is how are you using your current role to influence the spread of group clinics, Alicia?
So I'm actually working with ELC as an expert mentor on the Personalised Care Practitioner Advanced Skills Training. So I suppose I'm spreading awareness through doing that and helping to run the training course and coming to events like this and talking about my experiences. But if there's anything else I could be doing, I'm all ears. And yeah, I can't spread the true value of group clinics enough. So yeah,
we're having a meeting, aren't we, afterwards as well, Alicia, with some of your colleagues, about how we kind of get this going a bit more in Herefordshire, building on the experience that you guys have got and replicating that across your ICB. The other thing it's another one for you, Alicia. What is your process around measurement? Do you send a questionnaire before the last session and before the first and after the last, or do you do it in the session? That's from
so in the
Croydon.
experience that I've had in true sort of quality service improvement and redesign pathways and PDSAing, the first couple of clinics we definitely didn't do it in the right way, but that's okay because that's part of learning. But more recently the clinics have done it before they've come on to the session. So we actually did that at the beginning as well. So they'd send out an email with whatever questionnaire or survey that needed to be filled out with the outcome measures. But then if anyone hadn't completed it, they could do it in that first session. If it's sort of like a series of particular themes, then you can sort of do the outcome measure on the final one as well. And we've always found that doing it whilst the people are there, you get more responses. Whereas if you send an email afterwards asking them to complete it, you know, you're not going to get a huge number of responses. But it's definitely a learning process, but that's okay.
Absolutely. So I've also got, I'm going to give this one to you, Gosha. Lots of examples around health. Our caseload is so varied, from housing, debt, isolation. I'm trying to think, how would this work for my role as a social prescriber? Do you have any examples?
Absolutely. I think that this works beautifully for us. We use a cohort of group, for example, diabetes or respiratory problems, and invite those people in our PCNs. And just because, for example, when it's digital, there's no moments, you can really invite a lot of people. We don't have to be worried that very much if people turn up or not. And then we have, for example, a guest speaker as well, to specializing in, for example, diabetes. So like we had dietitian. And then with the patients, for example, which did not turn up, but usually so far we've been always very successful with this. Then we followed up with we had like a resource list made of things which would be useful for those patients. So thanking them for coming, or that we noticed that they didn't actually turn up for the session, and there will be a list of resources which might be useful for them. And that it helps them to be a bit more, look at the list, those ones, for example, which didn't come. Then also promoting us as a social prescribing service, and then wanting to come second time or third time with certain kind of sessions. And yeah, so we're looking more of certain groups of, I suppose, if there's a housing, then perhaps if you have a housing officer who can join the session, then you can invite those patients. I mean, for us was and still is a game changer. We're doing one-to-one, obviously, but also group sessions.
Yeah,
and
so
sometimes,
actually, yeah, so I'm just a bit concerned about time. I'm going to get Helen to just finish us off in a minute, Gosha, but I think that point is so well made. So our specialist colleagues who can, you know, who can help with housing, who can help with welfare benefits advice, we can actually make their lives easier by setting up group clinics, can't we? Because they come as a guest, they get to see and speak to 10 people in much less time than it would have taken them if they'd have had to have seen all of those people individually.